But welcome to this Goodfellow unit webinar. We are speaking on how to diagnose and manage common ENT problems in primary care today with Mr. Samant, who's with me this evening. He is a ENT surgeon at Auckland City Hospital. He specialises in the surgical management of snoring, obstructive sleep apnea, nose and sinuses. He's a member of the training committee for his college and also a member of the International Surgical Sleep Society. So welcome, Sumit, and we're looking forward to your presentation this evening.
Fantastic. Thank you so much, Helen. And thank you, everyone, for giving me this opportunity. I have to apologize at the outset for my voice. I've had laryngitis for a couple of days now, and I'm on all the meds that I can think of, and it's getting there, but not quite there. So again, apologies. As Helen just mentioned, a few disclosures, predominantly public, a little bit of private work is my clinical practice. I'm part of the training committee for the junior college trainees, part of the Auckland Surgical Vocational Training Committee, and primary interest in sleep apnea and rhinoplasty. So, in prep for this talk, I went through some papers and figures quoted around 10%, some papers say 30% of GP workload is ENT patients. And talking to the medical students and house officers at Auckland Hospital, the general kind of math was about 10% of trainees get any exposure to ENT beyond that 1 week of golden time spent in ENT departments during med school. And after that, you look after a variety of patients, different age groups, both genders, and variety of ENT problems. And to be honest, that's very remarkable. So hats off to you for the kind of awesome work that you do. So what I want to do, as soon as I can get the slide on, is I wanted to focus on a symptom-based or a problem-based approach to tonight, rather than, patients don't walk in saying, I've got sensorineural hearing loss. So we'll try and go through some of the symptoms that people present with in ears, nose, and throat, head and neck, that kind of thing. It'll be a whirlwind tour because there's a lot to get through. So if it is too quick, I'm very happy to answer questions afterwards, and then again through email or phone, whatever, my details will be up. So, common ear problems, you can see on the screen, hearing loss, blocked ear, tinnitus, vertigo, otalgia, common nose problems. A lot of patients will present with congestion, obstruction. They always have sinuses or the occasional epistaxis. In the throat, there'll be the general sticking sensation, globus, hoarseness, pain, neck mass, and of course my passion, sleep and obstructive sleep apnea. So to introduce the different symptoms and how I approach them and how it might be a good idea to approach them, I'll just present some scenarios. So the first one is patient presenting with a blocked ear, dull hearing, ringing, discomfort, dizziness, on and off, and then we have, that clinic consult to go through, work out the puzzle, see what might be going on. A nose and sinus patient, I always have sinus, nose is blocked, headache, and brain fog. I can't quite figure out what's going on. I'm not quite there. So, throat patient, sticking sensation in the throat with difficulty swallowing, a bit of weight loss, I'm anxious, I'm worried I might have cancer, croaky voice, swollen glands, and they point to their submandibular glands. What do we do? So looking at the ear symptoms first, hearing loss, one big factor, one big issue we have to always keep in mind. Is it sensorineural hearing loss? Is it sudden sensorineural hearing loss that can be salvaged? So we do tuning fork tests, Weber test, not very sensitive, but we should still try and do it. And of course, urgent audiometry is generally available. We are trying to set up an out-of-hours audiometer for the Auckland Hospital registrar on call, but a lot of audiology places will offer a free audiometry test within a few days, hopefully. And if it is within the 2-week window, then the patients will not miss out on a tapering oral prednisone treatment. It is advisable not to start that before they've had their audiometry, because then it might well be that they respond to the prednisone before they have had their hearing test, and then the picture gets a bit muddled. If you look at research, 30% of these patients will probably actually improve on their own, but you can ramp up those figures to 60%, and in some papers even 75% improvement, and that's worth a shot. And some patients, of course, you have to discuss the risks, and some patients are probably good candidates for salvage treatment with intratympanic DEX, or even as an alternative to oral prednisone or oral steroids if they can't tolerate them very well. We should repeat the audiometry to document what improvement, what change there has been. All these patients should have imaging to rule out acoustic neuroma or a degenerative type problem, because 10% of these patients will have something which underlies the problem, and it's not just idiopathic. The corollary to this, or the other side of the coin, is the conductive hearing loss. Patients will often hear their voices louder as opposed to sensorineural hearing loss, where they will shout or talk louder because they can't hear even their own voice very well. But in conductive hearing loss, the external sounds are masked, and you hear your own voice, so your actual volume goes down, and the partner or friends might say, "Can you speak up, please?" Again, Rhinitis and Webers are often helpful. Tympanometry will often clinch the diagnosis, because it might show a type C curve for a eustachian tube dysfunction, or a type B curve, or a sequelae chain fixation, and that will guide the management. Often it is because of eustachian tube dysfunction, so a good trial of 6 to 8 weeks of Flixnase spray will help. Some patients are quite desperate. They can't stand the autophony and the dullness and the blockage, and sure, they can have a grommet put in, often just in the clinic under topical anesthesia. But I try to kind of advise them that they should try the conservative management first. And that is because often they will come back, and in a couple of months, even with steroids, and they still have an effusion trapped within the mastoid air cells, and that keeps seeping into the middle ear. And so they still have persistent problems. But if they have had a grommet put in, oftentimes you can't be sure if that is going to give them that instantaneous improvement that they're after. And at the end of the day, it is still an invasive procedure, even if it is a simple thing to do. It does cause a degree of scarring. So my preference is usually to start to go with the steroid spray and then reassess, even in 4 weeks. Sometimes patients will present with an airborne gap, which looks like a conductive hearing loss on audiometry, but they report hyperacusis. They can hear their own eyeballs moving, or tuning fork placed on their knee, they can hear it, or they'll hear their palate moving, and so they report that as hyperacusis and a very weird tinnitus. And that actually turns out on CT scan to be a superior semicircular canal dehiscence. And the more you're aware of that possibility, when something is not quite making sense in the picture, often a cone beam CT scan of the temporal bones, it doesn't have to be a full-blown CT, it's easily available, and that might clinch the diagnosis. Moving on to middle ear effusions and recurrent acute otitis media. Broadly speaking, it can be a constant problem which fluctuates, so it can have acute exacerbations or acute increase in the hearing loss, and then gets better but never goes away. And compared to that, in younger kid age group, a recurrent acute otitis media type of picture. And the implication of the former problem is that there is an impact on hearing and therefore learning, and it's not just speech development delay, which will often catch up in a few months following insertion of grommets, for example. But in the past, we used to think, okay, particularly if it was a unilateral middle ear effusion, that the child could still hear well out of one ear, and that was enough, so we did not have to necessarily rush into anything. But modern research shows that binaural hearing is vital for not just speech development, but also brain development. So it's good to get in before or within that golden time of 2 to 5 years of age. The underlying problem is often eustachian tube dysfunction. We know that, and that can be because of adenoid hypertrophy, or even if the adenoids are not large, there might be a biofilm on them, and they are a constant focus of infection. And the child might be snotty. With large adenoids, they might be stertorous, they might be snoring, they might even have sleep apnea type problems. I always check for tonsils to see what size they are. Even grade 2 tonsils are known to interfere with the airway while sleeping. And I will have a frank conversation about the importance of that. Tympanometry will often confirm the diagnosis if we don't have, say, a pneumatic speculum to look for eardrum movement or lack of with fluid. And I talk to parents about grommets and with or without adenoids or tonsils.
Sorry, Sumit, just before you move on, someone was asking what the stertor is.
Stertor is just fancy talk for snoring. So
Great.
it's an abnormal, so like stridor is at the level of the larynx and voice box and trachea downwards. Stertor is high up, snoring.
Okay, and we had a question that came in before the webinar tonight about the effect of conductive hearing loss over a length of time for a child who had recurrent otitis media, and you've mentioned that with education and
that's exactly
speech.
Right.
So
we wouldn't want to delay that too much.
Yes. One more question was, what can be done but just a couple of slides back, for the superior semicircular canal dehiscence?
Great question. The great thing is that something can be done. So it can drive people nuts. We had a bus driver in Auckland Hospital who couldn't drive his bus because he could constantly hear his eyeballs moving as he was checking his blind spots.
Gosh.
And so there's a couple of approaches, one through the middle cranial fossa, so that's a neurosurgical approach, but also transmastoid. We can go in and selectively plug the holes in the superior semicircular canal. Not very invasive procedure, and that works a treat. So there are certain specialized audiometric tests that are required because patients can have bilateral semicircular canal dehiscence, and you want to address the more symptomatic one first. And when there are such vague and ill-localized symptoms, then you have to rely on some tests to figure out which one is the more problematic one and address that first.
Thank you. And the very last one on the slide is for eustachian tube dysfunction. Other than steroid spray, what other options?
Well, performing a lot of Valsalva or blowing balloons, there's not a great deal of evidence that it does help, but again, it's not going to harm anything. It's not going to make things worse. So if a parent is keen to have their child try that, there's absolutely no harm in that. If there is an element of allergic rhinitis associated with adenoid or postnasal space dysfunction, and we want to introduce another element, then I will often encourage patients to start nasal rinsing at the same time, just to try and get rid of all the allergens from the nose and just optimize mucosal function.
And the primary management for that recurrent otitis media is the grommets rather than steroid sprays and things like that.
To a degree, yes. Recurrent acute otitis media, I mean, in between episodes, they're fine. So it's, if the adenoids are a focus, then we have to treat the adenoids. And so that's where the spray comes in. And if despite that, then the problem is still there, the principle is essentially relief from discomfort. So that's where a grommet helps. It stops the pressure change. It makes the quality of life better for the duration that the grommet is in. So it's a symptomatic treatment. And again, if the adenoids are acting up, the parents have to understand that the child will have symptomatic benefit while the grommet is in there. But once it comes out, if the adenoids are the cause of the problem, then the problem will come back. So that's when often once they understand that, they'll say, okay, if the child is having an anesthetic, let's just have the adenoids done at the same time.
Great, thank you. We'll carry on.
So we've talked about the trial of steroid spray. Moving on, earache or otalgia is a very common presentation, common GP referral to the ENT department, and it'd be good to go through some of that. So of course, the more common and easily recognizable problems are acute otitis externa or acute otitis media, but also there's often question, does this child have mastoiditis? And the key thing, if you look at the slide, the sky blue arrow, that's where we have to actually palpate the mastoids posterior superior to the external auditory canal, rather than where the green arrow points towards the mastoid tip, which is where often you can find posterior lymphadenitis from an otitis externa or even a scalp problem. And that can be quite misleading. So a lot of referrals we get as mastoiditis are actually posterior lymphadenitis. So that's a crucial point of differentiation that is easy to kind of remember and practice. A temporomandibular joint dysfunction is a very, very common cause of earache that we see a lot of, and often patients have had antibiotics and ear drops for otitis externa and antibiotics again, but it's a muscular or a joint problem, because along with temporomandibular joint dysfunction, you get tightness of the masticatory muscles, and then as soon as you place a finger either on the pterygoid muscles through the mouth or on the outside of the temporalis or masseter or the joint itself, all is revealed. Myofascial pain is a common one, and if there are any physiotherapists out there, you guys do a great job once the patients get to you. And so often the pain around the cheeks, which I'll come to in the ear and sinus side of things, but also just pain all around, and particularly the upper attachment of sternomastoid. That is a very common side of pain, which people believe is from the ear. And once they understand it's muscular and they go get it addressed with physio, then it makes a big difference pretty quickly. But of course, we have to remember that referred pain from the throat coming to the ear is a red flag, and that needs a thorough endoscopic and ENT assessment. Otorrhea, suppurative otitis media causing mucoid, pulsatile, mucopurulent discharge. That's a pretty common and easy thing to pick up. But thicker discharge or debris within the ear canal could be from otitis externa, but also cholesteatoma right up top near the roof of the tympanic membrane, and that is an important thing to pick. And it can be painful or painless. Cholesteatoma is generally painless unless there's an intracranial complication. Otitis externa is usually painful, but in malignant otitis externa, often, which occurs in diabetics or immunocompromised patients, because of neuropathy or whatever, often they will not have pain. So the traditional teaching in malignant otitis externa, which is not malignant by the way, but it presents as if it's malignant, the hallmark is unrelenting pain, which used to be, which is still there in the definition. But reality is we're seeing more and more patients without pain, and so they're being treated for simple otitis externa for a long time before they start developing nerve palsies, cranial nerve palsies, or increasingly we are seeing a lot of immunocompetent patients getting that malignant otitis externa, and the scan shows skull-base osteomyelitis, because from the external canal the infection has gone through the pores and then it's traveled along the floor or off the skull base towards the central skull base, and that is still, even with improved antibiotic therapy, it's a potentially fatal problem. So that is an important one to just keep in mind. The principle of treatment remains pretty straightforward. You start with drops. Topical drops achieve concentrations much higher than oral therapy. Frequent 2 to 4 hourly instillation. The regular sensitivity of the swabs and all don't hold a lot of validity in the topical scenario or topical context. So any drop is fine, and you can swap drops. just frequent installation, and even with a wig, often for 24/7 effect. And then, of course, if the patient is getting systemically unwell, then they need oral antibiotics or even IV antibiotics.
Sumit, are there eardrops you can't use if someone has grommets or a perforated eardrum that aren't safe?
Yes, absolutely. We try and avoid Sofradex, and in fact, the choice is actually quite limited when it comes to ototoxicity. But often you have to balance the ototoxicity of the drops with the potential ototoxicity of pus and infected debris sitting in the ear canal, and particularly with a hole in the eardrum, having potential inner ear complications. So the general guideline is to try and stick to less ototoxic medication, ciprofloxacin, and regular oral toilet is quite important because the more the debris sits there, the more it keeps acting as an irritant.
Great, thank you.
Tinnitus is a very common one. So the way we look at the history of it is whether it is subjective or objective. So can I hear it when I'm seeing the patient in the room? Whether it is unilateral or bilateral, quite important. Unilateral tinnitus can be because of an acoustic neuroma, so they need a scan. Whether it is ringing, is it throbbing, or throbbing in time with your heartbeat, ticking sounds or pulsatile, or throbbing just from an infection in the ear or fluid present within the middle ear space. The duration and progression, if it is worsening, if it is a recent tinnitus that is worsening, that might be different from long-term stable tinnitus, and associated symptoms. So whether there is hearing loss or history of trauma or vertigo or oral fullness and headache. The common underlying secondary association is that of initiation of the threat pathway, because the tinnitus is right in the head. It's right next to the sense of self of the patient, and so it stimulates the adrenaline system, stimulates the emotional pathways, which cause secondary amplification of the tinnitus. So you can measure tinnitus in soundproof booths to see how loud it is, and untreated tinnitus is always louder, and then with treatment, with understanding, the same tinnitus will actually drop in sound. I should say even before treatment, once people understand and that sense of threat starts dropping, the actual intensity of tinnitus starts dropping. So that's something that I always talk to my patients about. So looking at the causes of tinnitus, there's of course tinnitus because you can hear your internal sounds more, because say there is, as the blue arrow points at the middle ear, if the middle ear is there's a fluid, there's an infection there, or there's a middle ear conductive deafness, it's masking the external sounds, you can hear your own internal sounds more, and people will report a whooshing sound or a low-pitched hum kind of sound, potentially from just otoacoustic emissions kind of thing. Or there can be a nerve damage related tinnitus, and that can be likened to a phantom sensation, which is a common explanation found in textbooks. It could be an objective pulsatile tinnitus, either because of an AV malformation or some kind of vascular phenomenon, or it could be a tinnitus from just increased blood flow within the masticatory or the neck muscles from a muscular cause, and that's very common also. So how do we manage it? Active listening and acknowledgement is really important, because the patients do have that sense of threat and impending doom kind of somewhere at the back of their mind, and because they don't know what's going on. And if we acknowledge that, and it doesn't take a long time, but as soon as people sense that we are on the same page, we're going to try and help them, that sense of lack of support and isolation starts dropping very quickly, and that I have found in my personal practice vital to kind of managing them well. I go through the etiopathophysiciology of tinnitus in detail, so just using the previous slide as an example, just different causes of tinnitus, and I'm frank with them to say, look, I don't know what might be the cause, but this is the potential. These are the few potential causes, and then let's work through them. always reassure them that no one dies from tinnitus, or no one, goes nuts because of tinnitus, generally. Vincent van Gogh being an exception. And I talked to them about the ladder of treatment, and the key being understanding that you need to kind of distract the hearing center from noticing those tinnitus sounds. Broadly speaking, retraining therapy and cognitive behavioral therapy has shown really good effectiveness in helping out with not necessarily quietening the tinnitus, but reducing the anxiety element of things. And patients will always ask, is there no cure? And again, if you explain to them that the people who respond best to management of tinnitus liken treating their tinnitus to a pet sitting on their shoulder, and so they change that negative association from tinnitus to a positive one, and that tends to quieten the secondary amplification. Dizziness is another big one. Broadly speaking, it can be cardiovascular, syncopal or pre-syncopal, blackout kind of thing. It can be a neurological one, a TIA, stroke, a degenerative condition, or a vestibular migraine kind of thing, or it could be true rotative vertigo from the vestibular system. In terms of history, I try and clarify whether it's a rocking boat kind of unsteadiness or a true spinning sensation, whether it is episodic or it is constant and then with some fluctuation, whether it is just seconds to minutes or hours or days or weeks or longer, and whether there are any triggers. So a lot of patients will report visual triggers, such as just the shower, water, patterns in the supermarket aisles, or driving around, just the trees flashing by, or road signs and such. And that is essentially just an overactive vestibular ocular reflex, which, if we understand about it, then we can do something about it. And of course, it can be postural, such as in BPPV. And we look for associated features: nausea, headache, tinnitus, hearing loss. If there's hearing loss and vertigo, then it can be a neurological and acute vestibular neuronitis or a labyrinthitis kind of thing, and patients will benefit from steroids within that critical window. So again, something to just be aware of. So what are the causes? We've talked about BPPV, endolymphatic causes, Meniere's type, transient expansion, increased pressure within the vestibular organ, the saccioutricle, and then half an hour later, for whatever reason, the blockage disappears or is relieved by vomiting, and then the pressure settles and the vertigo goes away. It could be neuronitis or labyrinthitis. The abnormal activation of the vestibulospinal and vestibulo-ocular reflexes. When you go on the boat, if it doesn't settle after you come back, then the patient can get an MDDS type of problem, and that can be quite disabling because you're constantly feeling like you're on a boat. Driving can be problematic, and there's a big element of overlying anxiety, and it's a difficult problem to manage. But one of the commonly used treatment exercises is essentially vestibulo-ocular gaze exercises, which can be quite helpful. And I've just talked about visual dependence, and again, vestibulo-ocular reflex and vestibulospinal reflex exercises will often help, and physio therapy with particular focus on these exercises can be quite effective.
Sorry, Sumit, there's a few people asking what MDDS is.
Maldebarkment syndrome. So basically, after you've disembarked from a boat, you get that maladjustment or kind of continued lack of adjustment to coming back on land. So continuous sea legs.
Yeah.
So management. The key thing that I want to get out right away, as soon as I've heard the history and I've examined them, is that, look, I understand where you're coming from. This is an uncertain problem. You don't know when you're going to get the next attack or the next episode. You don't know how long it'll last and how it'll affect you, and that's really stressful. So as soon as you acknowledge that, then they understand that they're in empathetic hands, and that starts to reduce the stress and the kind of jitteriness. And then again, I tell them, look, imbalance. Balance is fantastic. We do a complete translabyrinthine approach for a vestibular schwannoma, and we destroy one balance organ completely, and they are relying just on the other side, and patients are still fine. So I use that example to instill in them the belief that this is not something that they can't adjust to, they can't adapt to. And the key things being, you have to make some lifestyle modifications initially, be safe, do some particular exercises, whether it is vestibular rehabilitation exercises or BPPV type particle repositioning exercises, and you get some physio going. Drugs, they are often on regular antiemetics, Stametil or ondansetron. I try and get them onto wafers as quickly as possible so that it's a more PRN thing, and the less we suppress their labyrinthine responses, the quicker they will adapt. It's a bit like if your muscle is hurting, you have to rest, but if you rest for too long before getting into physio, then it just prolongs the whole thing. Short course of oral prednisone is often quite helpful as an anti-inflammatory or anti-emetic effect. Whether it actually does anything to the actual pathological problem, we don't know, but it is really good symptomatic relief. Beta histine, I mean, some people believe in it wholeheartedly, others don't. There are some really good papers that have shown good responses to endolymphatic problems or Meniere's type problems with really high dose beta histine. Not all ENT surgeons will subscribe to that school of thought, but it's a reasonably well tolerated medication, at least for a shorter empirical trials to see if it'll work. And there's no harm in trying it even at higher doses. 16 milligrams 3 times a day is the standard, 8 to 16, but you can go up to 48 milligrams 3 times a day. And a lot of patients will definitely require diagnostic audiometry and even imaging or balance tests.
Sorry, Sumit, you mentioned the doses for beta histine. For prednisone, what kind of dose would you be looking at for the management of the vertigo?
40 to 60 milligram once a day for 5 to 7 days, 5 days usually.
So relatively moderate dose for a short period.
Yes.
Yeah.
All right. So this hopefully will just make understanding or making sense of a patient who presents with kind of seemingly quite ill-localized problems or vague problems, getting to the bottom of the problem kind of a little bit easier. I don't know. Let me know if it doesn't. Moving on to nose. I'm going to try and speed it up a little bit. One of the commonest problems is nasal obstruction. So when the patient presents with obstruction, we want to know how long it has been there for, whether it is progressing or it is stable, whether it is structural or there's an element of soft tissue swelling or progressive weakness following trauma, whether it switches sides or not, and whether it is fluctuant or constant. Day versus night is quite important. Often nighttime obstruction is even from palatal collapse. So the back of the nose is blocked, but the nose itself is open. So the key is whether there is any daytime obstruction or not. This brings me to one of my favorite topics, nose questionnaire. So not just the nose questionnaire, but just questionnaires. And that's where a lot of you practice nurses can help. Before the patient comes in for a 10-minute consult, if they can sit out and fill out a few questionnaires. So I always get my patients with nose and sinus issues to fill out the nose questionnaire and the sinus questionnaire. For all my sleep patients to fill out the sleep hygiene, quality of life, Epworth, snoring severity scale, all those questionnaires, and we'll talk about that in a bit. As soon as the patient walks in, you've got a whole bunch of information that you don't need to then ask them questions about again, and that just speeds up the consultation. They've had time to think about all those problems while they're out there, and that is a fantastic tool. So nose questionnaire is a very well validated questionnaire for nasal obstruction. And then of course we talk about possible injury in the past or whether they have any nose allergy, hay fever symptoms. How do I assess them? So I look at the septum, of course, and you can see from the compared to the bottom picture, the top one shows deviated septum, but that's not the only thing. We look at the valves. So if you look at the green arrows, the patient's right nostril, the internal nasal valve, is quite narrow compared to the left. And if you pinch your nose right up there without blocking the nose completely, if you just pinch it gently there, you'll immediately notice a sense of blockage, and that's the internal nasal valve. You can have an external nasal valve collapse, so that's the orange arrow, or you can have, in the bottom picture, enlarged turbinates, or even polyps or masses or adenoids at the back of the nose, or even a foreign body in a child. I always measure their peak inspiratory flow just with a handheld PNIF meter, and that gives us a number to work with. And if the patient ends up having surgery, then it's a good tool to monitor how much the improvement has been afterwards. So that's a kind of comprehensive assessment of nasal obstruction. Patients present with nasal discharge. It can be unilateral for foreign bodies, or bilateral, intermittent or persistent. So that gives you the whole seasonal versus long-standing allergic rhinitis or atopic problem. Whether there is any associated sneezing, obstruction, or itching in the nose or eyes. Triggers such as in known allergens, irritants such as smoke, perfume, that points towards non-allergic or vasomotor rhinitis type of problem, and temperature changes, same thing. Other atopic conditions, asthma or dermatitis or food allergies. How do we manage it? Essentially, we have to figure out what it is. So allergic rhinitis or non-allergic rhinitis, classify it as mild, moderate, or severe, and depending on how bad their symptoms are, self-reported symptoms are, and whether it is intermittent or persistent. Also, when you're examining the patient and you see that the degree of obstruction is severe, then of course it's a severe problem. The different arms of treatment, avoidance. So based on identified allergens, then you can, whether it's a skin prick test or a blood test, then patients know what to avoid if they can. Not easy to do. Medical treatment in the form of steroid spray, antihistamine, and Univent or ipratropium for non-allergic rhinitis. And the rule of thumb is, for mild problems, you can have a PRN as needed treatment. For moderate problem, you should be ideally on a regular spray with breakthrough with antihistamine. And for severe problems, regular antihistamine, regular spray. And role of surgery is mainly for access, to improve the access for the spray and the nasal wash, sinus rinse or something. And selected patients can go for immune therapy. It's expensive. It takes 3 to 5 years, but it works well. So definitely worth at least informing of that option.
There was a question that's come in saying, is it a good idea to do broad allergy testing in children with chronic rhinitis?
I personally don't do that all the time. If parents are quite keen, then I will. And the problem, in my opinion, is avoidance therapy is really difficult to practice. So if it is something as simple as cat fur and their family is happy to give up their pet, then that's a relatively simple, not easy solution. But if it is house dust mite allergy or something that you can't really avoid, then what's the point of doing the test? Sinusitis. So I like to think of it in terms of where the problem lies. So which sinus. I try to kind of isolate it in my head based on the history that they're giving. Whether it is a recurrent acute sinusitis with intervening normal periods, or it sounds more like chronic sinusitis, and then it's just a recurrent acute sinusitis each time lasting about 7 days, probably more viral, or then does it become secondarily infected or bacterial and last for longer, a month or 2 weeks, whether there is any history suggestive of allergic fungal sinusitis, or if there is a dental focus of infection. So patients will do a SNOT-22 questionnaire in the waiting room. I perform an endoscopy to look at the middle meatal openings, look for edema, congestion, polyps, pus, mucus streaming out, and then they have a CT scan. I'm quite happy just to get a quick cone beam CT scan. It's easy, and the answer is there right away for you. And a combination of 2 out of these 3 will essentially clinch the diagnosis. treatment is medical or surgical. Medical treatment is generally maximum medical therapy with antibiotics, either doxycycline or oxythromycin, as per the EPOS guidelines. Short course of oral steroid and then steroid spray, nasal rinse, antihistamine, and then we reassess. And surgical treatment for recalcitrant sinusitis, which is not responding. If there is a surgical cause to treat, such as polyps or structural narrowing of the osteomeatal complexes where the sinus is open. The last line, congestion, stuffiness, facial swelling, brain fog, often that is non-sinogenic, and it's either myofascial pain or sleep apnea or grinding their teeth or something like that. And I will often kind of refer the patients for physiotherapy to see if that'll benefit them.
So we've had a number of questions come in about nasal rinsing, about how you would recommend patients do this and at what age children could do it, or whether they should be doing it at all in children.
Great questions. So my favorite spiel is, I can tell you to do it twice a day and use only the salt packets and boil and cool the water as per instructions, and it'll just make it more difficult for you to do, and consequently you may not do it. So I tell my patients, make the salt mixture with salt and baking soda. If you don't want to buy the packets, at least then you're doing something. Have that mixture equal amounts, sit in a coffee jar with the bottle, rinse bottle in your bathroom, and then just take half a teaspoonful of that mixture, put it in the bottle, fill the bottle up with shower water, and do it in the shower. Then it's part of your showering routine. It's not something extra you need to think. It's habit stacking. So every time you have a shower, you do it, and then you come out, you dry yourself, put the spray in, and it's all just one routine. And that seems to be the most kind of ease of compliance kind of thing. For kids, if the child is there in the room with me, then often I'll kind of engage with them, and I'll go about encouraging them to kind of try it. And it's not easy, but around the age of probably 8, a lot of kids will kind of at least show a willingness to try it. And then again, if I kind of sell it to them as it's part of your showering, just not on the outside, but also on the inside kind of thing, and you'll sleep better and stuff, then your eyes will be less itchy. They might be interested.
And someone said it was a full bottle of water to the half a teaspoon of the sinus rinse mixture.
That's correct.
Yeah, so very dilute.
That's correct. So a full bottle of the sinus rinse bottle, not a liter bottle, but for each bottle it's half a teaspoonful.
That's very practical advice. I love that shower one, so it's something that I'm sure everyone will use.
Yeah.
Thank you.
I find it difficult. I would struggle to do it, so then I want to make it easier for
Yes, it's not a pleasant thing.
Yeah. Epistaxis. So the history that I want to know from the patient is whether it is just scanty, mild, moderate, or severe. And not easy to quantify often, but still worth asking. Whether it starts trickling out the front or it goes down the back first. Are there any triggers, or does it happen just on its own? Any red flag symptoms, dental pain, blockage, paresthetic symptoms, diplopia, anything that's pointing towards a space-occupying tumor or something at the back of the nose. Excessive bleeding elsewhere. Any medication, blood thinners they're on, garlic and things like that as well. Any family history of bleeding issues. And I put HHT or hereditary hemorrhagic telangiectasia there. Not very common, but often patients, we have a whole bunch of patients who come to Auckland Hospital regularly for treatment for recurrent telangiectasia, so it's just there as a memory aid. It's best to, I always tell my patients what position to sit in to try and control the bleeding at home. And of course, the red cross on the right hand side of the screen is not the best way, because then the blood trickles down the back of the throat. Patients will cough, let go of the pressure, and then it's just a cycle of inadequate pressure and the bleeding keeps going. In the clinic, what I do is, instead of putting cofinocaine spray or some decongestant spray, I take a little bit of the pink 4% lignocaine solution, an ampule of adrenaline on a cotton wool pledget, and I pop that in the nose for a good 5-10 minutes. Patients go outside and sit in the waiting area, and I see another patient, and then I bring them back in, and on the left hand side of the screen you can see the normal vasculature blanches, and then the abnormal blood vessels are seen in better relief, and you can focus your cautery very effectively to a smaller area. And right at the bottom where the arrow points, generally from the floor of the nose coming onto the septum, there's a feeder vessel. And if I'm cauterizing the little area, I try and get that feeder vessel if it is visible, because often that will cause recurrent bleed if we've just cauterized the little area. And what I do is I slide that pledget of cotton wool further back posteriorly after I've identified the vessels. So when I'm cauterizing with silver nitrate, the silver nitrate doesn't just run back to the back of the nose. And then I pull that cotton wool out and rub it on the cauterized area to try and make it bleed. And if it bleeds, then I'll cauterize some more. And that's a little bit more foolproof. On the left-hand side of on the right-hand side of the screen, you can see the arrow pointing to a pyogenic granuloma. And those are quite difficult to control with silver nitrate. They're a lump, a vascular lump sitting there, and often they will need bipolar diathermy. But in the first instance, you can cauterize it, and I like to go from the periphery of the lesion and then towards the center if I can. But if it is small enough and just the head of the silver nitrate stick will sit nicely on it, then that just will cover it. But you have to be a little bit gentle, but leave it sitting for a bit. If you put it on just for a second and take it off, then it'll just start bleeding, and then you can't cauterize it. So gentle but sustained cauterization is the key there.
Again, that's really practical advice. What was that ratio of the adrenaline that you just a drop of each?
Just a drop, yeah.
Brilliant.
So 1 ampule of adrenaline and 4 or 5 drops of half a mil of lignocaine, something like that. Posterior epistaxis, difficult to control, but yes, if you are aware of the direction in which the pack has to go, so not all the way up, if you just follow the floor of the nose pointing towards the ear, then you can reach right to the back of the nose and then inflate the bulb at the back, and you're basically aiming for the venous plexus right at the back of the nose. So if the pack doesn't reach there, then often it will not stop the bleeding. And often if it does reach there, for example there, then you've got blood that wants to pour out the front, and often that'll come through as increased anterior epistaxis. Well, it's not increased epistaxis just coming out because you've effectively blocked the back, and then you can put Surgicel around the pack in the front if you need to reinforce it. Thankfully, it doesn't happen very often.
Yeah.
So that's the nose and sinus patient in a nutshell. Next, we're moving on to the throat. I'm conscious of the time.
Yeah.
Globus, a sticking sensation or a sensation of lump in the throat, and reflux. And patients will actually not report reflux necessarily. We have to tease that out, but globus is a common problem. So intermittent foreign body or lump sensation in the throat, and that's a big cause of worry for the patient. They will generally not have any dysphagia. I ask for a history of any aspiration and coughing and spluttering during meals or weight loss. They will not report reflux. They will report anxiety. I get them to do a reflux symptom index questionnaire in the waiting room. If the voice is affected, then you'll see later on a vocal handicap index or a quality of life questionnaire as well. I make sure that there's no otalgia, so it's not just a unilateral throat discomfort with a referred earache, because that's a red flag. How do I manage it? I have a look with the telescope and score the severity of laryngopharyngeal reflux, if there is any. Often you see, even through the mouth, you can see cobblestoning of the throat mucosa with granular kind of lumps seen everywhere, and bubbly, frothy gastric reflux fluid sitting in the throat. I see it with a telescope, even sitting at the back of the nose, so it reaches everywhere. And you can see eustachian tube cushions being pockmarked, and no doubt, patients get blockage of the ear or fullness of the ear sensations as well. Of course, I examine the neck. If there's a thyroid lump, then that is a useful thing to find, and more on that in a minute. I always reassure them that there's no cancer sitting there. And of course, you can't do that unless you've put a telescope in. And common lifestyle advice: avoiding spice, particularly late at night, avoiding alcohol, whiskey. That's my culprit, by the way. But the last weekend was not a good one. Smoking, peppermint is a big culprit, which people don't realize. They drink a lot of peppermint tea.
Wouldn't have known that.
Worsens reflux. I generally will prescribe them omeprazole 20 milligram twice a day, along with Gaviscon dual action liquid for both acid reflux and non-acid reflux. Late night, additional dose of ranitidine is often helpful, as is a prokinetic like domperidone. Patients are not settling down, then I'll ask one of my colleagues to do a transnasal esophagoscopy, much better tolerated than the regular OGD scope. You don't need sedation, you just have it done in the chair. There's topical anesthesia, it takes 10 minutes, and you get all the answers that you want, and you can drive home afterwards. And then, of course, in selected patients, we get PH studies done. I've said imaging there. So often patients will come in and they've had a neck scan and a thyroid scan with Globus, and then that opens another can of worms because there's a small nodule there, and then they go down the pathway of having that nodule investigated, and I'll talk more about that in a second. Hoarseness and dysphonia. Croaky or hoarse is often what patients will say. I talk about duration, whether it is progressively worsening quickly, any other associated ENT symptoms, red flag symptoms such as stridor or bleeding or weight loss, dysphagia, referrotalgia, lower respiratory tract infections, their quality of life, how it's being affected, and then to assess the patient, just to throw it in there, it could be stridor and drooling and hoarseness, and that could be, or change in voice, and that could just be an epiglottitis or a supraglottitis. And there's no obvious other element seen, but that is a true acute ENT emergency, and they should be in the hospital. But otherwise, I will analyze their voice just subjectively, listening to them on the Globus scale, which is grade of dysphonia, whether it is mild, moderate, severe, how rough the voice is, how breathy the voice is, whether it is really weak and they can't produce a volume, and whether it is a strained kind of voice. And that's a very well-validated scale, which it right away tells you, okay, what component of the voice is affected. The voice might be fine, but they might not be articulating the speech very well, so that's dysarthria. Or they might have big lingual tonsils or just large tonsils, or epiglottitis or supraglottitis, and the resonance of the supralaryngeal air column is changed. And so that's altered resonance, and a subtle sign and often not easy to pick up, but just something to be aware of. We assess their dynamic range. I won't try that because I'll fail miserably right now. And then a full ENT neck examination, flexible laryngoscopy. For professional voice users or even otherwise, often a stroboscopy is invaluable. Acoustic analysis, computer-generated programs that the voice therapist will essentially look at the changes in frequencies. How do we manage it? If it is a vocal cord palsy, often it resolves on its own. We do need imaging to see if there's a space-occupying lesion that's causing nerve compression anywhere between the brain skull, the base of the skull down to the chest level. Often patients have to wait for 6 months or so to see if it'll recover before they can have any intervention, such as vocal fold injection to bring it closer to the other one, or even external pharoplasty. Old age, the vocal cords become a bit bowed, so that's a bit like if you detune the guitar, and then patients will not get a good crisp voice. And sometimes vocal therapy of the muscles, physio of the muscles, will make the vocal folds tauter and their voice improves. Other times it's just so weak that you have to put in some injections that can be done locally in the clinic or as a GA. That'll plump up the vocal folds, and then with therapy their voice will get better. We treat voice misuse or overuse. Neurological causes, obviously, they will require specialist neurology assessment. Any kind of trauma is a really important one. Rugby player got hit in the voice box and they're fine, but 6 hours later they might develop a lot of swelling and go into airway strife. Same with thermal kind of inhalation of smoke or chemical caustic kind of inhalation. You get a period of seemingly normal voice and breathing, and then things can go downhill. So it's important just to be aware of that. Equally, if someone got hit by a soccer boot 2 days ago and they have come in with a bit of pain and a bit of hoarseness, then they do need assessment, but it's the crucial period is past and they're safe. I've said emotional trauma there. That's one of the true voice therapy emergencies, we like to say. Sudden kind of emotional overburden, and patients will just become completely aphonic, and they need to be seen pretty quickly. Otherwise, then they get severe psychological overlay, and then the problem just mushrooms.
Yeah.
And the principles of treatment are voice rest, which I'm not practicing, anti-reflux medication, yes I am, short course of oral steroid works really well in selected cases, and of course treat the underlying cause, voice therapy, sometimes surgery, as we've just discussed. Which bit should we skip?
I think this might be the one to go through, to skip past just for now. Maybe a brief look at this and then
all right
through.
So neck lumps or neck masses are a big one. So broadly speaking, they can be from lymph nodes, salivary glands, thyroid, or vascular masses. And we'll go through these really quickly in the next few slides. So lymph nodes, it can be a primary lymphoma, it can be a metastasis from either a skin lesion, very important in our part of the world. It could be a mucosal head and neck cancer coming to a lymph node, or it could be from the thyroid. In children in particular, if it is a lower lymph node, even in adults, but in children, lower lymph node, generalized lymphadenopathy, lymph nodes larger than 3 centimeter with hepatosplenomegaly or enlarged mediastinal lymph nodes, those are all kind of highly suggestive of malignant disease. Looking at cutaneous head and neck cancers, I'm going to go fast on this one. Most of them are pretty benign, 90% of them. You should remove them with good margins, they're done. But there are some bad eggs, and they are immunosuppressed patients, irregular edges and infiltrative kind of non-discrete, with history of, say, previous radiation in the area or chronic inflammatory ulcer in the area, and rapidly growing, and patient gets some neurological symptoms, so numbness or pain around it. And it's really important so those are the aggressive skin cancers, and we have to examine the parotid in the neck to look for lymph nodes. And the histological characteristics are often they're poorly differentiated, they're deep, thick tumors, and the degree of invasion, lymphovascular or perineural invasion, is greater. Mucosal head and neck cancers, the common ones, or the relatively current climate common important ones, are the oropharyngeal cancers, nasopharynx, larynx, and oral cavity in decreasing order of importance. Oropharyngeal SCC has just exploded with HPV, so they are all P16 positive. The demographics are different. It's younger, university educated, non-smoking, non-drinking, high achieving patient, educated, better prognosis. They respond quite well to treatment. As a result, we are looking at de-escalating the treatment so that they don't get the full chemotherapy, radiotherapy with long-term side effects. They are younger patients. They often have 4 or 5 decades ahead of them, and you don't want to cripple them with long-term mucositis and dysphagia and all of that. Transoral surgery, either with robot or endoscopic surgery, prevents a lot of morbidity. Key thing there is you see a lymph node, they're rapidly growing lymph nodes, and they necrose centrally, and they appear to be cysts, but it's important to be aware that cystic lymph node metastases are one of the hallmarks of this kind of cancer. Nasopharyngeal cancer, quite common in our part of the world with Chinese and Maori population. key thing is small primary. You may not even see it very well, but they've got early nodal mets, particularly down near the supraclavicular fossa. Modes of presentation are you will either see a neck node, but they won't have any nasal symptoms. Middle ear effusion, because it might affect the eustachian tube opening and you get a fluid hearing loss. And sixth nerve palsy, with the cancer spreading towards the abducens nerve. So diplopia, conductive hearing loss, neck node, common presentation. Hallmark treatment is chemoradiation. They generally respond quite well. Laryngeal cancer, this is the traditional old school cancer. Patients often will present with stridor, particularly someone comes over from the islands or they're presenting late. Relatively recent times, 10, 15 years, a lot of endoscopic laser surgery means that they don't have to have a total laryngectomy, and that can give good quality of life outcomes. And of course, traditionally, they have open surgery or chemoradiation. I'm going to skip this one.
Yeah.
Thyroid mass, quick one. So it can be a diffuse enlargement, either toxic thyrotoxicosis or a thyroiditis. It can be a multinodular goiter or a solitary nodule. 100 people off the street, 20 to 70% will have thyroid nodules, which are not palpable. 1 to 5% will have palpable nodules. 5 to 15% of all nodules will have cancer. So not a high number, and not all cancers are nasty. So a large number of people will go undiagnosed in their lifetime. And that's where vomit syndrome comes in, victim of medical imaging technology. So you have a scan for something else like Globus, and now you've got a nodule and you've got to go down that whole path. From the American Thyroid Association guidelines, you look at clinical risk factors, so whether there's any history of neck radiation, family history, that kind of thing. And then the TIRADS ultrasound classification of what the pattern of appearance of the nodule is, highly suspicious or benign. Benign, you don't need an FNA. And based on how suspicious the lesion looks on particular ultrasound characteristics, they can have an FNA even if they're a smaller size. And then on FNA, they get a Bethesda staging from 1 to 6, which tells us, so benign, highly low chance of malignancy, not a 0, but close to 0. And then the chances of malignancy in the nodule increases 15 to 30% in the suspicious category. And then in the indeterminate, the middle two, often on the FNA slide, you can do some molecular tests, which if they show gene mutations, then then it's a malignancy, and that can move it to the benign side or the malignant side. And based on then they can have either a diagnostic hemithyroidectomy, or if it is a proven malignancy, or if the patient just wants it out, then a total thyroidectomy. I'm gonna skip this one.
Yep.
This is fairly textbook.
In the interest of time, we're moving forward.
And this as well.
Yeah.
All right. So my favorite topic, and I'll try and be pretty quick about this as well. So sleep, broadly speaking, governed by the circadian rhythm. 8 hours a day is a good time to sleep for. Different stages of sleep, NREM and REM. And in the NREM phase, basically, the brain is forming new connections between the short-term memory that we have acquired and making sense of it all, and removing old connections. It's a bit like you've got a small USB stick and you've got to constantly look after it to have space in it. REM stage of sleep, towards the later end of the sleep, is where you're consolidating that memory and moving it into your bigger hard drive. And that is when you make outside the box connections. So is that the clever creative kind of thinking, where instead of going from A to B to C, you go from A to C to think lateral thinking. So the benefits are, it protects the cardiovascular system. There's a lot of repair work carried out to get rid of inflammatory damage to the endothelium. It increases the responsiveness of peripheral tissue to insulin. It reduces the level of inflammation. Inflammatory markers go down every night as we are sleeping, and it boosts the functioning of tumor suppressor genes, so it helps control cancerous mutations. We talked about the learning and the creativity, so that whole hippocampal short-term memory being moved to the long-term storage so that you free up the short-term memory for next day's activities, but also you're consolidating and making your memory long-term, and also thinking creatively. All that happens during the REM phase of sleep. As a result of that, our interaction with people are more positive. So they've done elegant studies where they've shown people same photographs and two arms, sleep deprived and non-sleep deprived arms, and the sleep deprived arms constantly overall scored those same faces as hostile or angry or not positive. And so human brains have disproportionately more important and longer REM phases. And one of the reasons why people think, evolution has basically allowed us that and allowed us to then grow as an intellectually superior species. And of course, that has economic implications as well. The more rested we are, the more productive we are, the more cooperative we are as a community, and we get greater things done. So what does sleep deprivation do to us? We can have hypertension because with sleep deprivation, the adrenaline levels, the sympathetic system is in overdrive all the time, and that causes endothelial and intimal damage, and that over time leads to IHD, in ischemic heart disease. Decreased peripheral tissue insulin sensitivity causes diabetes, causes obesity. They did studies where they got sleep deprived people and people sleeping 8 hours a day, and they had a whole table laden with junk food and veggies and celery and all kinds of healthy stuff. And the sleep deprived people who were previously very health conscious would go for all the junk food in the morning, and big jump in daily caloric intake just by changing the amount of sleep that they were getting. And that also actually relates to the proportion of the leptin and ghrelin hormones, how one controls or is responsible for the satiety, and one is responsible for the appetite. So one was overactive when you were sleep deprived. We've talked about how they affect our immune status. They've done studies where people who were sleep deprived did not show as good a response to the flu vaccine. Cognitive impairment, and the first word I've said there is decline. So there's decline in insight. So people who are constantly sleep deprived, like if you were drunk, often you don't understand how sleep deprived or how drunk you are, and so that becomes the new normal for them, and they're just powering on through the day with endless cups of coffee. And if you ask them, they will actually not report a high sleepiness scale score. Epworth score is really low because they're constantly just caffeinating themselves. Their adrenaline levels are high, and they're basically tired but wired. That whole transfer of short-term memory to long-term storage is impaired. So people, Alzheimer's and other types of dementia have been shown to be related to sleep deprivation, particularly in the prefrontal changes in the prefrontal cortex. And then psychological issues, a lot of psychiatric problems are associated with a lot of sleep issues, and it's difficult to say which is the which is the chicken, which is the egg, but there's a good correlation. And then, of course, a lot of conflict and kind of societal problems when people are sleep deprived. Not to mention the higher risk of accidents at work, particularly in factories and truck drivers and heavy machinery operators, and loss in productivity because of lack of concentration. our recent landmark study on 4-hour week in New Zealand, which showed increased productivity. That's amazing. So for moving on to OSA, the spectrum can be, it's a sleep disorder breathing from snoring to mild, moderate, and severe sleep apnea. We know about that. And then there's the upper airway resistance syndrome, where it's not quite OSA because each episode might be too short, but it still causes a lot wide fluctuation in heart rate and the adrenaline system. The pathophysiology, kind of reasonably well understood. The palate and the tongue collapse and impair airflow. This is an interesting slide, and I'll just go through this quickly. So this kind of relates to what happens every night when we sleep. So we've got a bit of upper airway collapse. It's variable. Some people will collapse even while they're awake, and others will not collapse at all. But that triggers the increased thoracic negative pressure, which we are kind of like sucking harder on a collapsing straw. And that stimulates, when it reaches the arousal threshold, then our brain will wake us up a little bit and open up the airway by the help of upper airway muscle dilatation action. And then we are kind of set with our airway again. So this leads us to some recent work on subtypes of OSA. So in some people, they have a problem with too much collapsibility of the upper airway. So that's where sleep apnea surgery helps, by widening the airway. Some people have the arousal threshold problem, where they have a very low arousal threshold. So they don't drop their saturation too much. They don't collapse their airway too much, but they wake up quickly. But that means that they're constantly waking up, and that affects their sympathetic system, and they're at risk of developing hypertension. Other people have problems with their upper airway dilators, the genio-hyoid muscle, which pulls the base of tongue forwards when you want to dilate your airway. That's not as effective. And so hypoglossal nerve stimulation, which selectively stimulates the muscle and does that based on when it senses collapse, is a good treatment. So moving on, how do patients present? They can present with physical fatigue because of sleep deprivation, heightened reflux because that heightened intranegative pressure, you're sucking air in, but you're also sucking acid up. So they'll wake up with a dry mouth, sore throat, but also a phlegmy cough. Then they'll spend the whole morning trying to cough out because it's all that reflux fluid and dried laryngeal mucus sitting there. They can have diabetes, obesity, hypertension, ischemic heart disease, heart failure, stroke, respiratory failure, reproductive issues because the testosterone levels go down. So when patients can present with so many different ways, how do we quantify how bad the problem is and therefore how to treat it? So traditionally, we've looked at the apnea-hypopnea index and the sleepiness scale or the fatigue assessment score, but that's just one aspect of the problem. So a lot of people, so this is a paper by a couple of really well-known sleep surgeons that have looked at an acronym of sleep goal, which basically looks at the snoring, the latency of sleep onset, Epworth sleepiness scale, vigilance testing, blood pressure, BMI, oxygen or desaturations at night, AHI, and also quality of life score. So just to get a really multidimensional description of the severity of the problem. And that basically, if you look at that slide, there's cardiologists involved, there's ENT surgeons involved, there's sleep physicians involved, and that basically pushes towards an MDT type of approach. And from an ENT point of view, I liken that to, say, sinusitis. People have medical therapy, but they have surgery, and the ultimate goal is to improve the quality of life of the patient. Same with hearing loss. You can have a hearing aid or you can have surgery, and sometimes you need both. With cancer, you need chemotherapy, radiation, or surgery, or a combination. So it's that same MDT approach which sleep apnea fraternity is moving towards more and more. And if you look at the standards, national standards published by the New Zealand Thoracic Society, they say oral services for upper airway assessment, that's mandatory. It's easy to say but difficult to accomplish, and that's why we still kind of operate in silos, but that needs to change, and it is changing slowly. If you look at the Australasian Sleep Association, their comment is that surgery for OSA is crucial as salvage if CPAP doesn't work or if the patient does not tolerate it. So I've actually designed this online program which records a whole bunch of parameters that I've talked about and some others that I haven't. And the beauty is that patients can log in before they come to their clinic and answer some questionnaires. And if I treat the patient, I put in all my upper airway endoscopic examination findings. Any surgery that I do, I can enter the data. If a sleep physician is seeing the patient, they can put in their CPAP parameters, they can put in their examination results, and basically it becomes a virtual MDT. So I've literally just finished designing it, and we're kind of in the testing phase, so watch the space. OSA assessment, so we've talked about patient-reported measures. I get my patients to do a 2-minute vigilance testing on the computer, and just that brings up how delayed their reaction times are. Any comorbidities, cardiovascular or cognitive, and then dynamic upper area assessment. So you can do it in the clinic, awake and lying down to mimic the sleeping position, or you can do a drug-induced sleep endoscopy. So two common, but they're both, rather than just putting a telescope in, you're actually trying to make the airway change by performing certain maneuvers. And then in certain selected cases where you are suspecting musculoskeletal or skeletal problems, narrow jaw, narrow maxillary dimensions, then you get x-rays done. And then of course sleep study. So a quick few pictures just to show what we look at. So traditionally you shine a light in the mouth and you see how big the tonsils are, how big the tongue is, and that's the end of it. But what we want to do is, for example, we are looking behind the palate with the endoscope, and then we want to see if the airway collapses front to back or side to side. So in this picture it's collapsing side to side because of large tonsils. And if you look there, the tonsils did not look too big. But over here you can see they're collapsing completely. And you wouldn't see that unless you did an endoscopic examination. Same at the level of the base of tongue. The tongue is here and the larynx is here. And when they perform a modified Muller maneuver, it just closes up completely. So that's basically just a complete collapse of the tonsils, which is causing the problem. Whereas anyone would look at this and say, oh, there's plenty of room at the back of the throat. They don't need any surgery. Another case, actually the same one. Apart from that collapse, you can see that the opening of the airway here, the laryngeal inlet, opens dramatically if they just slide their lower jaw forward. So when I see that, I tell them, look, I can offer you surgery and it'll work well, but why don't you go and try and splint? And if it works well, then you've avoided painful surgery. And in the same patient, at the level of the tongue base, like I showed before, the two tonsils were collapsing and causing a sideways pinch. And that's different from this patient where the tongue is collapsing completely backwards and closing the laryngeal inlet here. Now this patient will need something done to their tongue base, either surgically or a nerve stimulator implant. And unless you do that, just removing the tonsils is not going to help. And again, unless you do an upper airway assessment, you don't notice these things. Going back to the sleep study, so there's different levels of sleep study. I won't go into it in too much detail, but that's the gold standard sleep study where you sleep in a lab and you have at least 7 or 7 to 10 channels that are studied, and down to overnight oximetry or 3 channels. Level 3 and level 4, they can be done at home. This is the guideline by the Australasian Sleep Association about how to go about, who needs what. So forget about the algorithm, but the idea is if someone has a high probability of moderate to severe sleep apnea, not just mild sleep apnea, and they can do the test at home and they don't have any other sleep disorder or comorbidities, then they can do a level 3 to 4 sleep study at home. So that increases the accessibility of the test. Some studies, some papers have shown that up to 80% of patients in that fall in that category. And of course, if the sleep study does not show results that you were actually expecting, then they need to go ahead and do a level 1 to 2 study. And then if there's a low probability of moderate to severe sleep apnea, but they have significant comorbidities, ischemic heart disease, then they really should be having level 1 or level 2 studies. And the idea is, if you can get more people tested quicker and then treated quicker, then you're meeting them there rather than having the ambulance at the bottom when they've not had access to treatment and investigations and they've developed comorbidities and it's too late. Management. Primary one, lifestyle measures, quit smoking, reduce, and actually let's just go through that. So those are all the treatment options. Looking at the lifestyle, quit smoking, regulate alcohol intake, sleep hygiene, weight loss. And there's quite a few smartphone apps that can help with that. They're not medically graded, but they can still be helpful. And interesting development is like Fitbits or Snow Labs. They analyze your sleep every day. They're developing smartphone apps which will predict how you will be if you keep going at the same level. Wow. So 10 years down the line, how your face will look, how your blood pressure will be, what your ejection fraction will be if you have had a test. So they're probably looking at shocking people into doing something. Positional sleep test, so elbow, when you're snoring, is has withstood the test of time, but traditionally people would tuck a tennis ball in a sock and tuck it in their waistband. There are positional devices which will now gently vibrate and will not wake you up, but promote lateral position of sleep. So night shift and night balance are two of the machines available. There are certain smartphone apps that you can strap to your shin, which will vibrate gently without waking you up. Again, not medically proven, but or medical grade, but useful. There's positive airway pressure therapy, works really well. Long-term studies have shown that the best motivator is if you have daytime tiredness and you notice that it improves with use. If you don't have daytime tiredness, then people give up. And so the overall compliance rate can be as low as 46%. That's why a lot of sleep services, because they're so strapped for funding and resources, they will not even accept the referral if you don't have sleepiness, even if you might actually have significant OSA. And that's just a sign of times. You can try a mandibular advancement splint, which essentially pulls the lower jaw and the tongue forwards. 60% effectiveness in trials. It is expensive because it has to be custom made, and long-term use does cause some changes in your jaw alignment. Surgery. Across the world, the sleep physicians talk about maxillary and mandibular advancement surgery as the proven surgery. Yes, it is, but a lot of blood loss, quite morbid. It's a big deal to get someone to get that done as the only surgical option. Bariatric surgery is well accepted. The jury is kind of out on that still, but there are some good results shown. But oropharyngeal surgery is increasingly becoming recognized. Traditionally, it used to be just chopping out part of the palate and the uvula. And as you can see with the blue arrow, that was the direction of the scar. So over time, it would actually start closing in. But modified UP3, which is done now, which is this kind of worldwide accepted way of doing it, creates these scars which pull the palate apart over time. So they cause sustained results or gradually improving results with time. And you most often retain the uvula, so you get good mucus clearance and less of Globus type sensation that people with traditional surgery used to get. Palatal advancement, if the hard palate is too long, occasional selected people will get that, and a combination of that and soft palate surgery is considered to be as effective as maxillary advancement and less morbid. Tongue base reduction, so the blue circle shows where you can go in orally with these needle devices, radiofrequency devices, and create an ablation which will pull the back of the tongue forwards and open it up just with minimally invasive procedures. And of course, there are more extensive procedures available, but done only very select few patients. Hyoid suspension to pull the hyoid forwards, which pulls the back of the tongue forwards. Some centers do it, not all. And then the latest kid on the newest kid on the block is the hypoglossal nerve stimulator, where you put in a cuff electrode around the green arrow, the terminal branches which supply the genioglossus and the geniohyoid, which basically pull the tongue forward. So it's not available in Australasia at the moment, but hopefully soon. And 5-year results from that surgery are fantastic. So we've talked about surgery. What are the outcomes that we look at? Traditionally, we've looked at the AHI, how much has that improved, but look, that's just one number. Now we're looking more at how often every hour your oxygen levels are desaturating, or what the lowest saturation level is overnight, and how much time of what proportion of the sleep was below 90% saturation. Those are, in some studies, shown to be better correlate of the cardiovascular risk to the person. Daytime sleepiness, of course, is a big issue. So someone with a high AHI may not be too sleepy, but at the same time, if a truck driver is too sleepy, then that's not a great thing. Same thing with vigilant test results. So psychometric motor vigilance test results, carry a lot more meaning for a heavy machinery operator compared to, say, a desk worker. Control of hypertension might be something that someone is looking at. They don't care about whether, their partner is affected by their snoring. They just want better blood pressure. And someone might want to lose weight or, control their diabetes better. So there's different outcomes that are more meaningful to different people. And performance and productivity in the workplace, to say the least. So what is the outlook? What is the best cure for OSA was the traditional question, and there was endless debate about, what is the best gold standard treatment. The point is now we all are coming to the same conclusion that we can't actually cure it, but we need to control it the best we can. And even if someone is headed to increasing complications and we get them some treatment which is not perfect, but it brings their curve down and they then keep going along the same slope, they're still at a lower risk overall across their lifetime. So that's what people are moving towards more and more, whether it is sleep physicians or sleep surgeons. And we can see success depends on what parameter we study, and therefore the treatment is more and more personalized based on what the objective is in each patient. And we like to say, if you come for treatment, then you basically become friends with the patient for life, because it is an evolving process. What is a great result now will probably be different 5 years, 10 years down the line. CPAP, if they're at 14 centimeter of water pressure, they might need more later on. So it's not like they're in and out the door and then you forget about them.
You've covered so much, Sumit, and it's been amazing. Those practical tips have been really helpful for people. We might cover a couple of very fast questions, sure. And then you've mentioned that you don't mind being in contact, so we may have to answer some of these after
Absolutely.
tonight.
Look, I'd love to do that, because I think the more closely we work together, back and forth, the better we do for our patients.
So there are a number of questions from right back at the beginning. Sure. I think we've got here, we talked about, does chronic rhinitis issues in an 11-year-old post-tonsillectomy and adenoidectomy at age 5 with nocturnal polyuria, are they related? There's been a lot of discussion coming in through the attendees tonight about the relationship with bedwetting.
Yes.
And ENT issues and sleep deprivation with children.
Fantastic. That is such a great question. So secondary enuresis, whether it started after a period of good control or even prolonged enuresis, is in kids as well as adults, where people have to wake up 3, 4, 5 times every night a night to go to the bathroom, is seen as a sign of increased sympathetic overactivity. And so in kids, now that question in particular, where they've had an adenotonsillectomy at the age of 5, and they've got rhinitis and enuresis, it could well be that they've got allergic rhinitis causing nasal obstruction, and that causes them to mouth breathe. And even with the lack of tonsils, if you look at the jawbone and the mandible mouth opening, the back end of the mandible pushes the tongue into the retrolingual airway and creates an artificial narrowing at the back of the tongue. And that might be causing a bit of sleep disordered breathing and secondary enuresis as a result. So if I saw someone like that in the clinic, I would treat them with spray and try and optimize their nose and see if that makes a difference. And sometimes they require a turbinate cautery. They're 11, they can have cautious submucosal diathermy or even a cautious limited tomioplasty, and see if that improves their overall clinical picture.
Fantastic. There's a question here that also is related to the questionnaires. Are there specific ENT questionnaires you would recommend for the age group of young people between 12 and 24 years that we could be using in primary care? You've mentioned a lot in the session. Are they all useful from that point of view?
Absolutely. So broadly speaking, look, I don't do as much of ears in public because at Auckland Hospital we've got the otology service. But they're still, I'm happy to send those through to you if you like. But there's specific tinnitus related, for example. I mean, that's not going to be a big problem in very young patients, but tinnitus quality of life questionnaires, I've talked about, and there's Vertigo quality of life questionnaires. And then for the nose, I tend to use the nose questionnaire and the SNOT 22. The two together are sufficient for me. And for sleep apnea, like I mentioned, the snoring severity, there's a FOSQ 10 quality of life questionnaire, or the San Francisco 36 Berlin questionnaire, Epworth sleepiness scale. Stop bang is really important. I didn't put it on a slide, but that's essentially snoring, tiredness, obstruction, blood pressure, BMI, age, neck circumference, and gender. It's available very easily. And that, if you score 5 out of 8 or 6 out of 8, then you're pushing the high probability of sleep apnea kind of thing.
Okay. Thank you. We'll put some links through to that on the website afterwards. Ciprofloxacin, are there any other options for patients with otitis externa who have grommets or perforation that cannot afford ciprofloxacin drops? It's the common problem in primary care.
That's right, yes. Look, they can have a short course of ciloxan, which I understand is becoming a little bit more easily accessible, provided you can show that they're not responding or they're not suitable for any other treatment. Oftentimes you can start with those antimicrobials in the short term and then move on to acetic acid based drops such as Bosol. And often I will alternate between the two, because if you look at the American Academy analysis or guidelines for treatment of otitis externa, they say that it's not the eardrop, but how you use it that is actually helpful. So just increased, more frequent or enhanced delivery, so more frequent installation or with ear wicks tend to work well. So even with the limit on the number of the eardrops I can use, generally patients will need to come back a little bit more frequently for cleaning, but they generally tend to respond well.
And actually that leads to another question that was asked earlier about how we advise our patients to do oral toilet of their ears without sending them to an ear clinic.
Yeah, that's a difficult one. So it's really not that simple to do, unfortunately. Yeah. And the problem is whatever you try at home does have a risk, because you're not doing it under vision of actually causing a micro trauma to the skin, and then bugs can get under that crack and then maybe worsen the problem or worsen the swelling, even if you don't create a lot of trauma. So that's not an easy one.
Yeah. And lastly, because I know we're running out of time, or we've run out of time, this is a sleep question about a particular patient. So doing a medical assessment in a male over 60 years, moderate to heavy alcohol consumption, high blood pressure, obesity, a snorer, denies daytime sleepiness, has a low Epworth sleepiness score, but is a professional driver and has risk factors for OSA. Should they be offered a sleep study, level 1, 2, or a level 3, 4?
Yeah, great question. So they are not very sleepy, but they, based on what you've described, are at a moderate to high risk of sleep apnea. So they definitely should get a sleep study. Now, you haven't mentioned any cardiovascular problems. So they could have a sleep test at home, and maybe if they don't actually think they have sleep apnea, they will perhaps be more amenable to doing a test at home rather than going and sleeping in a lab. So you could start with a level 3 or 4 test, an overnight oximetry or an apnea link type of study. And if that shows moderate to severe sleep apnea, then that might motivate them to actually start treatment right away. But if it doesn't, then there is still a role for a level 1 or level 2 sleep study. Absolutely. But the hurdles there that I can see are, they will often, any sleep service that they go to, unless they pay in private, they're likely to be told to control their alcohol intake or smoking or things like that first. And often even then they will not get, an accepted referral because they are not sleepy, and CPAP works best if you're sleepy. So, but the fact that they're a heavy machinery operator is a big red flag. So they will probably still get accepted on balance at a sleep clinic.
For that risk.
Yeah. So in fact, as I'm giving you an answer, I've actually arrived at a better answer, that yes, absolutely, they should be referred to a public sleep service, because most services, if the patient is a heavy machinery operator, they will accept them at least for a level 3 study, if not a level 1 study.
So they will start that process.
Yes.
And someone has just snuck in at the very end there, which is it's my understanding that short courses of Sofradex with grommets in situ is okay. Is this correct or not?
Yes, it is. So my otologist colleague, who I will often ask for a phone a friend advice, will say that yes, absolutely. And he uses Sofradex for short courses for sure, because again, if someone's got ear discharge and their round window is constantly being bathed with mucopurulent discharge, that has as high a risk of inner ear damage as does a short course of Sofradex.
Thank you. And thank you, everyone, for your patience tonight with our microphone dysfunction. And I'm afraid we haven't been able to get to all the questions, but hopefully we've covered the majority of it, and Sumit's covered a huge amount of material in this. So thank you again, Sumit, for your wonderful presentation. We appreciate it.
Thank you, Helen. It was a pleasure.
Care. And good night, everyone.
Good night.